All right, guys. Good evening. Hi, guys. Good evening. Good evening. Dr. Sandeep here. I'll be taking your surgery session. Welcome to a quick recap for the INICET. I hope everybody is preparing well. Everybody is doing well. Now, the objective of this session is going to revise all the previous year questions that we had in your INICET in last 5 sessions, right? So I've clubbed them together in 100 set of questions. We'll go on a rapid pace. We'll try to know what exactly have come and where do you want or should focus on, right? So let's dig in. Okay, feel free to ask any questions in the chat box. If you have any queries, any context, just put it across here. We'll be addressing at the same time. Now, the first question that appeared on your exam was about the neurogenic shock. So shock has been your important previous year topic. So anything that has come in the previous year, we call it as the PYT. So PYT is a previous year topic that has been asked in your exam. Okay. Now, in the neurogenic shock, any shock is associated. When I say shock, it is systemic state of hypoperfusion or tissue hypoperfusion. Shock is associated with hypotension, and whenever there's decrease in pressure, what will happen? The baroreceptors are going to get activated. The activation of baroreceptors will result in activation of sympathetic system, catecholamines, epinephrine, norepinephrine, heart rate will increase. But here in neurogenic shock, the sympathetic drive is lost. Because the sympathetic drive is lost, the heart rate falls here, right? So the only thing to remember in neurogenic shock, it will be associated with hypotension and bradycardia, not tachycardia. Rest all the other shocks. So you talk about the hypovolemic shock, you talk about the cardiogenic shock, you talk about septic shock. Everywhere you will see heart rate will increase, the heart rate dips in your neurogenic shock, right? So that's the objective to be remembered in the context. It will be hypotension with bradycardia, right? Now, if you talk about Cushing's triad, Cushing's triad is where, or you will see in raised intracranial pressure. The Cushing's triad is seen in raised intracranial pressure. Here you will see this presence of hypertension with bradycardia with irregular breathing or irregular respiratory rate. There will be irregular respiratory rate. That is a Cushing's triad, so do not get confused in the same context. Okay. Now, the second question that they asked you is about your systemic inflammatory response syndrome. Which of the following, all of the following are the criteria of the systemic inflammatory response syndrome, except again, systemic inflammatory response syndrome has been your previous exam topic, right? Now, in your systemic or systemic inflammatory response syndrome, what are the components to be remembered? Can I expect a feedback here, guys? Quick feedback. Right. So the components that are involved, number one is going to be temperature, right? If the temperature is less than 36 degrees Celsius or if it is more than 38 degrees Celsius, I would say it is one of the component of SIRS. The second is going to be heart rate. If the heart rate of the patient is more than 90 beats per minute, again it is considered to be one of the component for SIRS. Another one is increase in respiratory rate. If the respiratory rate is more than 20 cycles per minute, again it is a component. Number 4 will be your WBC count. If the WBC count is more than, if it is more than 12,000 or if it is less than 4,000 cells per cubic meter. If any of the following is present, we call this is going to be a component of systemic inflammatory response syndrome. That is, SIRS is taken across. It is the systemic inflammatory response syndrome or the SIRS criteria. And here, which of the following is not there? Systolic blood pressure is not a component. Temperature is, respiratory rate is, heart rate is. So answer here is A for Ahmedabad, right? So here again, SIRS is an important component to be considered. Yeah. So this is with respect to systemic inflammatory response syndrome. Now, your question number 3, which is again about the electrolyte imbalances which are important. We have an elderly woman who underwent a surgical resection for her bowel. after few months she presents with easy fatigability and tiredness. Okay? Blood smear evaluation shows there is macrocytic anemia. Resection of the all of the following can be causing this except. Now remember, when you talk about the anemia, so it is usually associated with jejunal as well as ileal resection. Now, here when we talk about jejunum, we basically talk about B9 deficiency. Ileal resection is going to be B12 deficiency. Whenever there is a stomach resection, in this, obviously, when you remove the stomach, the parietal cells will be lost. It will cause decrease in Castle intrinsic factor, which is transporting the B12. So, B12 will be found here. Right, so you will see jejunal resection, ileal resection, and stomach. All of them will be associated with anemia. So, jejunum will be, ileum will be, stomach will be. The one which is not associated with anemia will be duodenum. It will be duodenum, right? So duodenum is not associated with anemia, as simple as that, right? Chalo. Next question. Now, question number 4: which of these is the most life-threatening injury that can be identified by assessing the breathing component of the patient, right? Based upon the breathing component of the patient, you're looking at it. Now, remember, cervical spine injury cannot be assessed on breathing, right? So, cervical spine injury has to be ruled out on the basis of the nexus criteria. I hope everybody remembers it. Just brush nexus criteria. It is the National Emergency X-ray Utilization Study criteria, where you have to take an X-ray to rule out cervical spine injury. Along with that, there should be no midline cervical tenderness. Tension pneumothorax, yes, you will see there will be increased respiratory rate. You will see decreased air entry onto, there is a decreased air entry onto the affected side. You will see the trachea deviated to opposite side. Trachea deviated to opposite side. So the respiratory rate will increase, obviously, to compensate, right? Cardiac injuries or blunt trauma, where if it is going to develop into pericardial tamponade, if it develops into pericardial tamponade, in a pericardial tamponade, you will see presence of Beck's triad, right? In the Beck's triad, you will see presence of number 1, there is hypotension. There will be raised JVP, and there is muffled heart sound. And there is muffled heart sound that occurs, right? So decreased blood pressure, increased JVP, and muffled heart sounds are the component that are seen. Laryngeotracheal injury will result in the congestion but not on the breathing pattern. So the answer here that can be assessed is going to be tension pneumothorax. It is going to be tension pneumothorax. Now, if there's a tension pneumothorax, the investigation of choice is going to be clinical examination. In emergency, what will you do? You will do a needle thoracocentesis. Where would you insert the needle? If it is an adult, it is going to be 5th intercostal space on the mid-axillary line. If it is a child, 2nd intercostal space in the mid-clavicular line. Definitive, you will put the ICD. Where will you put the ICD? In the 5th intercostal space in the mid-axillary line in the safety triangle. That is the component to be followed across here. So trauma is again a very, very important component to be remembered. Now, next question. I have an old female with 32 years old female with Graves' disease with eye signs, enlargement of thyroid, planned for total thyroidectomy. What can be given in to reduce intraoperative bleeding? Now, to decrease the vascularity, I have to give thyroid constipating drugs. Now, the thyroid constipating drugs are sodium iodide, potassium iodide, and Lugol's iodine. Right? Now, potassium iodide can be given. Propanolol, it inhibits the peripheral conversion. It does not decrease the vascularity. Propyl thiouracil. Propyl thiouracil is going to inhibit thyroperoxidase enzyme, and it inhibits peripheral conversion. Another important point about propyl thiouracil, it is safe in pregnancy. Now, it is a steroid. Steroid also inhibits peripheral conversion. So the one that decreases the vascularity is the thyroid constipating drug, that is your potassium iodide. So the other drugs which decrease the vascularity is sodium iodide, potassium iodide, and Lugol's iodine. Right? Question number 6. Which are the following places? In all the following places, hand rub can be used according to a standard hand hygiene protocol, except Now, where you cannot use it, if hands are visibly soiled, hand rub can be used. See, if it is visibly soiled, you have to wash it. So this is wrong. Yeah, while moving for a contaminated site to a clean site, yes. Before donning a glove, yes. During the direct patient contact, yes. There you can use hand rub. But if there is a visible soiled one, you need to wash it. Common sense. No, if you have dirt in your hand, you can't just put hand rub and go. You have to do a proper hand wash. The answer here is going to be A for Ahmedabad. Right. Question number 7. Question number 7. Which is the correct sequence of management of patient who was presented to casualty with the road traffic accident? Right. Now, you have the option cervical spine stabilization, intubation, IV cannulation, and CECT. Right. Now, of all, the least important is CECT. So, CECT will be last. First is going to be airway with cervical spine stabilization. I would stabilize the cervical spine. I will intubate. I will look for cannulation, and then required I'll get a CECT done. So the 7th, it has to be 1, 2, 3, 4, and that is going to be B for Bombay. Right. So the objective is ABCDE protocol. A is airway with cervical spine stabilization. B is breathing and circulation. C is going to be circulation. B is breathing and ventilation. C circulation with hemorrhage control. D disability limitation. E expose and examine. This is the sequence that you have to follow. Question number 8. What does the magnified number marked on the Foley's catheter corresponds to? You see this 14 French, it indicates the outer circumference. It indicates the outer circumference. It indicates we're talking about the outer circumference. It's not the diameter. We're talking about the outer. French means outer circumference. Okay? So it shouldn't be outer diameter, it should be outer circumference. It has to be outer. The French indicates outer circumference. Okay? French indicates outer circumference. Question number 9. We have a 49-year-old female with the breast lump, which is in accordance like basal cell carcinoma of the breast. Now, now you have luminal A criteria, luminal B, you have basal cell type, and the HER2 neotype. Now, the objective about this, it is on the basis of ER, PR, and HER2 neogene status. In the luminal A, these two are positive, this is negative. B, all three of them are positive. Basal, all three of them are negative. These two are negative, this is positive. Basal cell, you have triple negative. Where you're triple negative, all three are negative here. C for Calcutta. So basal cell type is what we call it as the triple negative breast cancer. Again, an important question from your previous exam component. Okay. Question number 10. Now, question number 10, we have a patient with a chest x-ray finding of pneumothorax. Which of the following is not the boundary of triangle of safety? I just told you that triangle of safety. It is going to be by pectoralis major, latissimus dorsi, inferiorly by 6th rib. 6th rib, pectoralis major muscle, latissimus dorsi. This is going to be the mid-axillary line. You will put in the 5th intercostal space. So it is the 5th intercostal space, slightly anterior to mid-axillary line. It is anteriorly formed by pectoralis major, posteriorly by latissimus dorsi. Which is not the boundary? Lateral border of the pectoralis major, yes. Mid-clavicular line, no. Base of the axilla, it could be lateral border of the latissimus dorsi. Right? The answer here is going to be B for Bombay. Mid-clavicular line is nowhere near safety triangle. Right? Safety triangle is a site where you will insert the ICD. Yeah. Now, question number 11. Which of the following cancers are correctly matched with the criteria for minimum number of lymph nodes required for pathological staging? Alright, now here is an important. Now for CA breast, for carcinoma breast, you need minimum 12. Okay? Then you have carcinoma stomach, you need minimum 10. For CA colon, you need again minimum 12, right? For carcinoma gallbladder, you will require 6. Now CA stomach you require 16, sorry, not 10. CA stomach you require 16. That is the minimum number of lymph nodes required. Okay. Now, so which of the following is correctly matched? CA breast is 12, DCA breast, no, it is wrong. It is written as 15. CA stomach is 16, CA stomach is 10, this is also wrong. CA colon is 12, CA colon is 12, CA gallbladder is 6, CA gallbladder is 6. So BC are correct. So BC is option number A, right? So option A is correct. These are the minimum number of lymph nodes required for staging. Yeah. Okay. So these are the staging protocols in terms of lymph node clearances that are required. Now, question number 12. All of the following are true about acute cholecystitis except, right? Now, ultrasound gallbladder thickness should be more than 3 millimeters. 3 millimeters on ultrasound. This is true. Murphy sign is positive. This is also true. Leukocytosis there. Preferential visualization of gallbladder in HIDA. See, HIDA, there is non-visualization of gallbladder. In HIDA, there is non-visualization of gallbladder. In fact, HIDA is considered to be the gold standard. HIDA is the gold standard. So answer here is going to be D for Delhi. Answer here is going to be D for Delhi. Okay. So these are the first set of questions which were asked in your last year's INICET. Okay. So moving on to the next one. Which of the following statements are true regarding central vein access and peripheral venous access? Right? Okay, let's look at it. Phlebitis is common complication in peripheral venous access. It is true. Isotonic saline and heparin are flushed to retain patency. Now, when we say in terms of heparin, heparin is given always to prevent the collapse or to prevent the thrombus, and hence it will maintain the patency is correct, right? In an arteriovenous fistula is present in limb, avoid peripheral venous. Yes, obviously when AV fistula is there, I cannot take a peripheral access. It is wrong. Vasopressors for septic shock are given in central line to avoid limb ischemia. Absolutely correct. All four statements are correct. So C for Calcutta 1, 2, 3, 4. All four statements are correct in this context. Question number 14. Which of the following is not a relatively contraindication for breast conservative surgery? Right? Now, remember the contraindication for breast conservative surgery is, or I can say, rather than saying contraindication, we'll say indication. The indication for breast conservative surgery. Number one, size less than 4 centimeters. Size less than 4 centimeters. Limited to 1 quadrant. There is absence of microcalcification. There should be absence of microcalcification. Absence of lymphovascular spread. There should be absence of lymphovascular spread. It should be less than 4 centimeters, limited to 1 quadrant. There should be absence of microcalcification, absence of lymphovascular spread, and patient should be non-pregnant. It should be non-pregnant. So which is not a contraindication. Size less than 4 centimeters with N1 lymph node metastasis, right? Remember, if there is size less than 4 centimeters, it is actually an indication. If there is N1, that is ipsilateral axillary group of lymph nodes are involved, and that too mobile, right? Then you can look across it. But this is not an absolute indication. But yes, we're talking about which of the following is not a relative contraindication. Tumor more than the size of the breast, it's a contraindication. Chest irradiation, yes. Multicentric tumor, all these are the contraindications. Size less than 4 centimeters. Involvement of lymph nodes is an component, but again, I would be a questionable of all these. Option A looks better. Okay, but for that, concentrate on the indications for breast conservative surgery, right? For the breast conservative surgery. Now, question number 15. Which of the following is not a perineal approach? Not a perineal approach for the condition shown in the image. Now, condition shown here is going to be your full thickness. It is your full thickness rectal prolapse. It is your full thickness rectal prolapse. Now you have the abdominal approach and you have the perineal approach. You have abdominal and the perineal approach. Abdominal is going to be Rebstein's, your modified Rebstein. Your Rebstein's, your modified Rebstein's, they are considered to be abdominal. For perineal, the important one is going to be 𝐒𝐻. This is your 𝐒𝐻 wiring, right? Which of the following is not a perineal approach? As you can see, option number A is clear. Rebstein's and modified Rebstein's are going to be abdominal approach. 𝐒𝐻 is going to be a perineal approach. Delrooms. Delrooms is also a perineal approach. Okay. So, not a perineal approach is Rebstein's. Rebstein's is an abdominal approach. Question number 16. I have a 37-year-old unmarried nulliparous female with regular intercourse, okay, is on OCPs. Okay. Her mother was diagnosed with carcinoma of breast at the age of 60. Her elder sister was diagnosed with ovarian cancer at the age of 40. What is the next line of management? She's 37, first degree relative with breast ovarian cancer syndrome. It is HBOC syndrome. For any HBOC patient, screen for BRCA mutation. All first degree relative or screen for BRCA mutation. So answer here is going to be A for Calcutta, right? A for Ahmedabad. So whenever there's a BRCA mutation positive, if the BRCA mutation is positive, you will see the family status, complete family, or if it is in complete family. If it is a complete family status, then I will opt for risk reduction surgery. I'll opt for risk reduction surgery. Incomplete, age less than 25, more than 25. Less than 25, do nothing. More than 25, get an MRI every year for screening until she is good enough, right? Once she completes her family, get an MRI on an annual basis. So answer here is going to be A for Ahmedabad. Talking about question number 17. In question number 17, I have a 50-year-old alcoholic patient with history of waxing and weaning of jaundice. This itself is enough. Waxing, weaning of jaundice associated tumor, right, for past 2 months. CT reveals a dilatation of the CBD and the pancreatic duct. The most probable diagnosis is the most common probable diagnosis, because the pancreatic duct is also dilated, I will go with the periampullary carcinoma. So why I'm saying periampullary carcinoma is the periampullary carcinoma is the carcinoma that is around that region. It could be distal cholangiocarcinoma, pancreatic head malignancies, duodenal malignancies. All these are considered to be periampullary and they will present with waxing and weaning of jaundice. End of discussion. Question number 18. The following procedure performed for the management of, what is this? You see there is a loop. Hepatogegnostomy is there. You're saying pancreatogegnostomy, and then you have duodenogegnostomy. It is pylorus preserving. Whipple surgery, or because it's pylorus preserving pancreatoduodenectomy. For what will you do for periampullary carcinoma? Not for stomach, not for gallbladder, not for chronic pancreatitis. It is going to be distal cholangiocarcinoma, because distal cholangiocarcinoma is a variant of your periampullary carcinoma. Okay. Question number 19. I have a patient who had a grade 3 splenic trauma, was managed conservatively in ICU. Which of the following signs on day 2 would indicate the need for surgery? On day 2. Now, hemoglobin fall from 12 to 10. It is fall, but it is not significant, right? Extraperitoneal bladder rupture. Now, extraperitoneal bladder rupture can be managed by Foley's catheter. It could be managed by the Foley's catheter. Presence of pneumoperitoneum, that is important. Pneumoperitoneum indicate hollow viscous perforation. So if the HB is dropping, I can go ahead with blood transfusion. Air in the gallbladder indicates pneumobilia. Pneumobilia you can avoid, but it's not that dangerous. But pneumoperitoneum is what it requires your urgent attention. It requires your urgent attention, right? Now, question number 20. Identify the true statement regarding the split skin and full thickness grafting. Split thickness is going to be 𝐒𝐻. Full thickness is your Wolfie's graft. It is your Wolfie's graft, right? Now, what is the true statement? Okay, primary contracture is more in split thickness skin grafting. Secondary is more in split thickness. It is wrong. Secondary contracture is more in split thickness. That is correct. Primary contracture is more in full thickness. That is correct. Secondary contracture is more. No. So second and third statement are correct. Answer is going to be A for Ahmedabad. Right. Remember, in a full thickness, more is primary contraction, less secondary. In partial thickness, more is secondary contraction, less is primary. Less is going to be primary contraction. Okay. So, question number 21. Which of the following causes maximum malnutrition? More proximal the fistula, more malnutrition it is going to be associated with. You see pancreas, duodenum, ileum, colon. Which is most proximal? Duodenum is the most proximal one. More proximal, more electrode imbalance. Answer here is B for Bombay. It is B for Bombay. Right? Which investigation is not necessary for the following condition? Which investigation is not necessary for the following condition? When you look across here, it is a classical barium. You see esophagus is dilated. There is a thinned taper defect here. A thinned taper defect indicates the component here, right? Which investigation is not necessary for the following condition? When you look across here, you see that narrowing indicates a growth, right? Now, which of the following is not necessary for the following condition? Okay. Now, I would have appreciated a bit of history across here. Now, barium study, endoscopy, esophageal manometry is done for motility disorders. Now, motility disorders is achalasia cardia, diffuse esophageal spasm. It does not look like this, right? 24 hours pH monitoring is done for GERD. Now, what GERD can result in Barrett's, and Barrett's can result in development. The Barrett's can result in the development of adenocarcinoma. So, when you're looking at the malignancies, you can do these three, whereas esophageal manometry is not required. So, C for Calcutta would not be required across here. Question number 23. A patient developed a loss of sensation over the root of the penis following an open hernia surgery. Okay. Which of the following nerve would have been implicated? It is going to be the ilioinguinal nerve. It is the ilioinguinal nerve. Iliohypogastric nerve will result in development of chronic pain, that is inguinodynia, if it is going to be trapped inside a mesh. Okay. The lateral, okay, not the medial one. If I say what is the most common nerve damage in open hernia surgery or open inguinal hernia repair? In open inguinal hernia repair. In open inguinal hernia repair, the answer for open inguinal hernia repair is going to be ilioinguinal nerve. It is the ilioinguinal nerve. Now, the most common nerve damage in laparoscopic inguinal hernia repair, it is the lateral cutaneous nerve of right. Now, question number 24. Which are the following statement about the psoas abscess is true? We are looking for psoas abscess and a true statement. Fluctuant swelling in the hip, true. Cold abscess can develop, yes. The POTS abscess, TB abscess can result into psoas abscess. Pain on passive extension of hip is also seen. It develops more commonly through hematogenous. Yes, in especially TB, no hematogenous route of spread will result in development of the psoas abscess. All four statements are correct. A, B, C, D. That is 1, 2, 3, 4. All four statements are correct. Now, we have another question. A 34-year-old woman has brought to the AIMS emergency following a road traffic accident. She was hemodynamically unstable and her GCS score was at 3, right? She was intubated and sent for a non-contrast CT, which had the following, which was normal, which is the most likely diagnosis. Patient coma post trauma. It is going to be diffuse axonal injury. It is a complete disruption between the axons in the white and the gray matter, between the white and the gray matter. NCCT will be normal. MRI is the investigation of choice. For diffuse axonal injury, MRI becomes the investigation of choice. And MRI, there will be presence of punctate. There is presence of punctate hemorrhage on MRI, which tells you that the patient is having or the patient is presented with your diffuse axonal injury, right? So these are the components to be remembered with respect to the statement in accordance.